All right. Well, thank you again, everyone, for taking the time. What we'll start with, and you can go around the virtual table, so to speak, is what is patient journey? What's the solution that you're aiming to develop? And then we'll ease into the why and what it will be known as. So maybe start with what is the patient journey solution?
Kate, this is Jeff. Did you direct that question to anyone in particular?
Not to anyone in particular. So if someone would like to just jump in and then pass the question around the virtual table, that would be great.
Okay, and I'm sorry, I walked in just a moment late. Can I get a quick roll call of who's on the phone with us?
What I have noted is Stacy, Jesse, Nan, Paul, Allison. Am I missing anyone? And, of course, Ken and myself on this end. 1, 2, 3, 4, 5, 6. That should be right.
Okay. Thank you. So I'll go ahead and take kind of a first stab at this. And for the group, just to help ensure some additional clarity, I just mentioned this a moment ago in our stand-up, but we've been working on definitions of the various concepts that are sub-elements of patient journey. And what we're doing now is kind of taking a step back and looking at patient journey as a whole, which is something that was still needed just in order to ensure that we, as an organization, first as this team, and then secondly as a ZINCSAT whole, have clarity around this. So, Kate, to address your question, my thinking is historically ZINCS has addressed clinical decision support in somewhat of a siloed fashion. So predominantly from the acute care hospital, but then to a lesser extent also from sort of an ambulatory care perspective. And due to changes in the marketplace, predominantly those value-based reimbursement strategies, moving from the traditional fee-for-service to a value-based reimbursement strategies, healthcare systems are concerned about how a patient moves throughout the continuum, ensuring that the patient goes from the area of highest cost to the area of lowest cost as appropriate, and reduces the incidence, reduces the return of the patient to areas of higher cost. So what the patient journey does is addresses that same core value proposition of things, which is providing evidence-based clinical decision support, but now addressing it from a continuum perspective. So initially addressing it with each of the respective levels of care, acute hospital, long-term acute hospital, acute rehabilitation, skilled nursing facility, but even more so stitching those together so that a health system could use the output of our patient journey to facilitate the most appropriate movement of a patient through that continuum and reduce the likelihood of bad outcomes, clinical outcomes associated with moving through that continuum.
Perfect. Thank you, Jeff. And so is this perspective being woven in across all of your products, or is this a separate solution?
Or is it a philosophy more so than a product or a solution?
Well, I'm a little reluctant to speak for the entire group, but nevertheless, I think that in the short term, I don't know philosophy. I think philosophy is not quite the right concept, but we certainly are struggling to we're making progress in this, but what we're doing is identifying the terms and concepts and then applying definitions to the terms and concepts such that we can begin to sketch out a product solution. So I think, and again, I'll look for validation from everyone on the call, but it will become a product. It's not a philosophical discussion per se.
Okay.
Our goal is to determine a minimally viable product or products, and then begin to test that and see what we can build and sell. It's likely that it will become integrated with or in some way tied to the other Zincs product. It's not likely, in my view, to be a completely standalone product, but it's important to, I think, for us to be in an agreement that we're not talking about enhancements to our existing products. We're talking about new products that are very likely to be offered as a suite of solutions.
So would they, I guess, looking at it, would this be something where you're going to take, maybe you just said this, but going to take elements of your current products, perhaps, maybe add some new things, and then just create something new out of that? So it could be like, the part that goes with the hospitals, you may already have that piece of it, but now it's how does that get applied on a broader basis so that also the post-acute care, a SNF, assisted living or home health care, how all of these other pieces are fit into that overall, say, a plan of care.
Yeah, that's exactly right.
Okay.
Yeah, and so, for example, some of the patient education elements, we have those content in our acute care content, and we'll be leveraging for other settings as well. And one of the advantages of doing this is that we'll make sure that there is a consistency without creating any confusion to the patient. So the education teaching elements will be consistent no matter where the patient is.
Okay.
And, Nan just brought up something that I should have mentioned when I was talking initially about the big picture on patient journey, and that is traditionally Zincs has not thought about how to incorporate the patient into our solutions. And the patient journey is very much cognizant of the role of the patient in their own healthcare journey and how to bring that to the patient, how to bring the patient into that. And if we can, I'd like to ask Nan, and I call out Nan, but I'd also just like to ask anyone else to also speak to the very first question that Kate asked, because I don't want to be the only voice in this discussion.
Jeff, I agree with what you said, though. I think as I thought about it, it was, clinical content coupled with technology that helped an organization provide the appropriate care at the appropriate level for the patient. And so, I think it kind of ties into what you said, but it's really that piece that we're so focused now on inpatient, but now it's really, helping organizations to provide that better care throughout the entire continuum. And to do that, we're going to have to couple, do what we do, but add new technology to it.
Right. And I would agree, Paul, everything you said. The part that worries me a little bit is the technology but aside from that, just to give a tactical kind of add on to what Nan said. So, we have content, and it says what you should educate your diabetic patient on. But typically and it's robust and it's huge. But when we put that in the acute inpatient setting, honestly, what the acute people are just trying to do is get them safe and stable enough to get to outpatient. And then the outpatient people then need to say, okay, this is how you need to manage your condition. And so we're trying to take the content we have and expand it so that so that, as Nan kind of mentioned, when you're inpatient, we start here and educate you on A, B, and C, and now you're outpatient. I can see that you were educated on A, B, and C, and we need to augment that with D, E, and F, and just help continue that journey, whether you go to a skilled nursing facility or back to your provider or what, just help facilitate what the best interventions are based on where they are. That helps.
That makes sense. So previously, would you have had D, E, and F in the acute care because it was kind of, everything that you knew about helping a diabetic patient, but it just the D, E, and F part of it wouldn't be covered, or was that not really included because it wasn't germane to the immediate issue?
Well, and that's a good question because D, E, and F they are in the acute setting, but what we find when we go to implement our products is D, E, and F are really not appropriate right now. They need to happen, when the patient's home or wherever they're going to end up. So our content is robust enough with some augmentation that we do have D, E, and F, but just parsing it out in the right place is kind of how I see it.
Okay, that makes sense. So as you actually get access to those other levels of care, you can start placing the content where it fits best rather than trying to be all things to all people in one setting.
Right. So each product would have its, there will be a uniqueness within each product for that specific setting, and there will be also consistencies across the products.
Mm-hmm.
So you'll have seamless interoperability between your products, and it will be customized in that not only is it the right information in the right setting, but it's also the type of information that the patient is ready to consume. So it's best time for the patient to understand it and act upon it.
That's an interesting point, Kate. So Nan and Stacy, do you envision that we would continue to some extent our everything in the kitchen sink in terms of educating the patient and allow our clients to begin to customize what they want delivered in the acute setting versus the outpatient setting? Or do you anticipate that we would apply those filters ourselves and guide the content before the client even lays a finger on it?
I think that we would guide, right?
I agree. And the other thing, too, that makes me a little nervous, though, when you say interoperability, I mean, we are still just the content operating in somebody else's operability or whatever you would call it, their EMR. So that part I'm still a little unclear on.
Yeah, to me it sounded more like, I guess part of the thing is all right, so someone gets through the acute care part, they're given certain instructions. Without something like Patient Journey, they may go to the post-acute, they might go to their primary care physician and get different instructions because that physician either has different experience or is using a different content source or for whatever reason. Now with what you're doing, you're really going to try to standardize that across so that patient hears consistent instruction, which will make it a lot easier to execute rather than confusing them with conflicting information.
Right, I think of it.
Go ahead.
Sorry, go ahead, Jeff. Oh, I was going to say, I think of it like a lot of hospitals are trying to standardize their education pamphlets. So the inpatient, like with HealthWise, that's a vendor, they want the same pamphlets to be inpatient as outpatient. So at least the look and the feel are the same. And the content may be similar if they go to a different vendor, but at least there's some standardization too. And for us, ours are evidence-based of what we should be doing. So that again, you're doing the things based on the evidence and not just on what that provider chooses.
So also add to, I think Kate probably mentioned the right care, right venue. We also want to add right moment. It means that our content needs to be presented to the in the workflow and present it to the users at the right moment. So it doesn't appear to be overwhelming.
So if I can, thank you, Nan. If I can, I want to provide our Amendola friends with just a little more context. First is patient journey is a name that we've applied to work that this team is doing, but it's an overarching term that just applies to all of our work. There are a number of different products and product concepts that are included under the patient journey. So, for example, all of our post-acute care content, which constitutes a number of different settings, as well as chronic condition management content that most likely applies to, say, a call center or a cross-continuum health care manager or care coordinator. In addition to that, we're looking at clinical protocols or care care pathways, which are different concepts than the historical care plans that we've talked about. In addition to that, we have a potential software solution that is a transition management or facilitation tool. We've got a working name on that software product called Bullseye. And then there's a different product concept that's coming to us from outside the organization it's got a working title of Bundle Tracker. So first, I just wanted to be clear. Patient journey is an umbrella term. It's not a product in and of itself, at least not today. It's a number of different things. And then the second point is we're approaching patient journey first from our historical construct, which is creation of clinical content, order sets and plans of care. And we're very much, to the point Stacy was making earlier, we're at this point in time very much dependent on the software solutions that our clients are using to display the content that we've created. So it's not uncommon for us to have, say, a 5-hospital health system, and all of their inpatient hospitals are utilizing Epic. But they have a physician network, and some of the physicians are using Epic outpatient, but some of the physicians are using NextGen, and some of the physicians are using Athena Health, and some of the physicians are using eCentricities or other. Point is, there's a myriad of different platforms that are being utilized, and typically when someone's talking about interoperability, they're talking about the ability for data to flow from one of those systems to another. And the point Stacy was making is right now we're basically hostage to what systems our clients are using and to what extent those systems are able to talk to each other. And as a general rule, the answer is not very much. Now, the next thing, though, that we want to consider is there a role for Zinx to play in developing a solution that facilitates that care planning, and I'm using a very encompassing term of care planning or clinical decision support, if you will, to facilitate the transfer of that information from one setting to the next for any particular patient. So first we're starting with the content. Our investigation may demonstrate that we need to build some kind of a software solution that helps facilitate that exchange. But it's not exactly clear what right now, I mean, all we're doing is defining the product, beginning to identify what we think our clients' requirements would be. Over time, we'll work with those requirements to determine what a minimally viable product is, and then begin to test to see whether or not a minimally viable product is able to be sold. So I just wanted to provide what I thought was a lack of clarity over sort of all the moving parts that constitute patient journey.
So it sounds like there is an element of interoperability that's going to have to come in at some point, most likely.
Exactly. The question just will be, is that something that Zinx is creating and facilitating, or is it something that's happening outside of zincs? And the answer may be both, but we don't know that yet.
So patient journey, as Jeff and Stacy mentioned, it covers the care continuum and care transition, right? In addition to that, and also will be more comprehensive than what we currently offer. So it covers age continuum as well as the disease continuum too. So if we use diabetes as example, from pediatric to emerging adult, which means transition to adulthood, to childbearing age woman, to adult and elderly. So the care plan, if there's information, then we'll present the age specific care plans. So it actually follows the patient from pediatric to elderly. And also regarding the disease continuum, also use diabetes as example. We'll cover pre-diabetes, diabetes, and then, patient might in the future develop complications or comorbidities, and all this will be covered.
Great. Thank you, Nan. Fascinating. Okay. So to the team and Jeff, since this is a little different, it's both going to apply across some of your new products and potentially lead to a new product, and there may end up being a technology aspect to it as well. So content, absolutely, that's your stronghold, your differentiating factor. And there may be that technology play of interfacing throughout the care continuum. Since this is a bit different than the other work streams, Jeff, maybe I could pose that to you. Where could we help you best? We can look at industry needs, but some of our more typical questions in terms of competitive advantage and why to buy aren't as applicable given that this is a new scenario.
So, Kate, that's a good question. We're I think, still looking for consensus and clarity over what is patient journey. I think we're getting closer as a work group in terms of what that is, but it's not there. And if we were to walk outside of this room and ask 5 different people in the company, we'd get different answers. And even more so if we were to take the sub-elements, the various items that we're working to define across the industry, we would struggle to find consistency or agreement around what these mean. A good example is the difference between a longitudinal care plan, a chronic condition care plan, a care pathway, a plan of care, all of these terms. And so what we've been working to do is just come up with a zinc definition. That is, what is the textbook or textbooks describe these, and what do our clients call these, or how do our clients define these terms, and then come up with a zinc definition. And we believe that if nothing else, if this work team produces nothing else, we will at a minimum generate a paper, a white paper that says, these are the standard definitions, this is what we as an industry should agree these terms mean. So the messaging pillar was designed to help us have consistency when we're at HIMSS and throughout the rest of the year to talk about these topics. But I think as the work stream is progress, we're also just finding there's an opportunity to actually help us come up with definitions and generate those for the industry.
Hey, Jeff, this is Paul. Just had a question kind of based on that. If we thought about ever doing some sort of a focus group. So I know HIMSS is coming up short, so I'm not sure that's the time. But, you know, a lot of times I've been at a couple other companies that have used HIMSS as a way to do focus group, where they do this presentation, kind of like our patient journey presentation, and get feedback, you know, kind of a big bang for your buck, you know. I'm just wondering if we've ever thought about doing something like that to try and progress this a little bit further than the 1Z, 2Z interviews that we're getting.
Thanks, Paul. As you were talking, Jesse was in Jira creating a task for you to take points on helping us set up a HIMSS focus group.
Love it.
I'm kind of kidding because Jesse wasn't literally doing that, but we're going to do that. So you don't necessarily need to take a point on that, Paul, but thank you. That's a great suggestion.
And the only reason I asked, and I think if one of the other companies, I believe that company also used Hammondale, and they were someone that helped. And so that made me think when Kate said, is there something, how can we help you? That kind of triggered my thought. And I don't know if that's something that they do, but.
Well, one thing is that I think that Zinc in the past has used HIMSS as a platform for conducting those focus groups. I remember product management used to do that. But the other thing that I agree with Paul is that for patient journey specifically, because it's not a product yet and we're still in the process of getting feedback from the market, we can think about, rather, like for the purposes of Kate and her team and how they can help us, we should probably think from the point of view of what kind of feedback do we want to get at HIMSS. And so can we use HIMSS to start testing how the different value propositions resonate, and iterate on our own understanding of how different people in the market, you know, perceive the value of some of these proposed products.
And Jesse, I believe that, Jesse, you were taking it just where I was thinking too, which is I think definitions are absolutely important. People will also want to know how it impacts them, so reversing it and say, you know, what's in it for me? How will it make their jobs easier? How will it improve patient outcomes? How will it lower the cost of care? So maybe some of the points that we've talked about in parallel to working on the definitions of and Nan had mentioned the right care, right setting, right moment. How is what is being proposed and talked about here, how is it going to be different than what's out there right now? And part of it is, of course, you know, your evidence-based care, but that might be an interesting conversation to have now is, in your vision, how will it be different than what's already out there?
Well, and so this may be kind of way offline, and I apologize if it is, but as you guys are talking, I keep thinking, and I think that's a great point, like what are the returns going to be on this product? But the people we've talked to, they're like, we want it now. Like, whether we have all these definitions defined, they're like, we want ambulatory care content, so which is really, you know, finite, or we want this content, which is finite. I just, again, maybe totally off field here, but I just sometimes worry that we're spending so much time with definitions and all this stuff when people are saying we need this content now. Just kind of like we missed out with home health with Ohio, is they've already developed the content. So they wish they had the evidence-based content, but they've already developed it. So at this point, it's not really.
Thanks, Stacy.
So really, I guess, you know, as we look at this, and you know, we've talked a little bit about it, what, you know, with the messaging that we're going to do on this particular pillar, are you looking more for something that you can test in the marketplace right now to say, here, you know, here's what we're thinking. Does that resonate with you? You know, when you're talking to people at HIMSS, and then get their reactions with the thought that you'll refine it further after getting that kind of input?
Or are we looking more for internal facing messaging?
I guess, are we on a messaging journey right now?
I appreciate your question. I don't know that I have a good answer for you. I'm wishing Jimmy was here, but he's gallivanting about Asia at the moment. Jimmy's our product manager for this, and ultimately everything that we're doing is to help facilitate his output. Let me turn the question back to you. Given what you've heard from us so far, what's your inclination? How do you think you can most help this team?
Well, I mean, I guess, my question was really my answer is at this point, you're not really committed to anything. There isn't a there that you can sell to someone today. So probably what we're doing at this point, at least in my mind, is really trying to capture the essence of what it is and to say this is where we're headed on the patient journey. This is the sort of thing we're going to do. But the thought is that the messaging, we're not looking to come to a conclusion with it that is at HIMSS. It's more of a starting point. So there'll be an output that can be used at HIMSS, but that, to me, I think, and Kate, you can disagree, but, that once you've been at HIMSS and have tested this out a little bit more and all that, it provides not only direction on the product or the solution itself, but also in how we describe it.
Agreed. And I would add to that, so when we do surveys, focus groups, et cetera, you always approach it from the perspective of the end. So for example, questions I would pose that I think would be interesting to discuss even now is, what do you, each of you personally, either from your personal experience or your conversations with those within Zinx or even in the field, what do you feel is missing in your current products as well as in competitive products? So what's that market gap right now that the patient journey philosophy, future solution, and potentially technology could address? So what's that gap right now? And that would be the first one. And then what are the drivers right now that are different? So Jeff spoke to this at the very beginning. It's value-based care. Finally, organizations have to embrace value-based care contracts. So that is a big one, but that's only one. And I think by further delving into that and identifying perhaps the sub-drivers, then we can make sure that you can target those pain points of the people that want something, because they may say, for example, we want content, but if you can speak to the why they want content, how it's hurting them, then you'll get their attention. Because again, that parlays into, again, not just the pain points, but the story and the emotions behind why they want them. How is it hurting them not having it?
So I just want to jump in here too, because Jeff said something to me a while ago that has really helped me kind of think about this. We have a lot of fluffiness and questions around what we're calling things, how it's going to go from vendor to vendor, from inpatient to outpatient to post-acute to ambulatory. But one thing he said to me that I try to remember is that at the very least, they want the same content in each of those venues. So in that example of HealthWise, they want the same look and feel to their education so that even if they're in PT or if they're get hospitalized or if they're at a SNF, or they go to their doctor's office, it's the same look and feel. It's got the same, it's the same source. And so when you look at our company, in my opinion, we are evidence-based. That is our gold star. We do it in a systematic way that other people don't do. And what everybody is trying to do is bring evidence-based practice to clinical support, to clinicians to give care to the patients. So in my mind, when I take a step back, I just say we need to get evidence-based practice at all these different places. And then we can figure out as we go down the road how that's all going to interact. But at the very basic, get that same standardized evidence-based content to what you should do for that patient in that setting. And that's something that I just think I have to remind myself when I get caught up in how is this going to work with Epic? How is this going to work with outpatient? But I'll pause there and let somebody agree, disagree?
Well, Stacey, I naturally agree. Citing things that I've said to you in the past is a great way to get my buy-in. But my opinion changed since I said that to you, so thanks.
So really then, I mean, to a large extent, it sounds like the gap that Kate was talking about is that content tends to end at the four walls of whatever setting you're in. It might, if you're lucky, it might carry over to somewhere else because they happen to be using the same resources or the same information, but there's no real consistency. There isn't a path. There's a lot of different paths, and so the patient can meander, could become confused, could give up, do all these other things. So what we're looking for here really is something that says, we're going to create this pathway from beginning to end, wherever beginning is and wherever end is. It's all going to be consistent. It's all going to be designed to work together, and that's how we're going to improve those patient outcomes. We're going to take all of the meandering out of it and really have a direct way to get there. Is that a fair summation?
Let me just elaborate a little bit. Kind of to restate what Stacey was just alluding to, and so at the start of your statement, Ken, you said, well, let me just say, currently an evidence-based plan of care, most likely the only care setting where that might happen. Let me be more specific. A Zincs Health evidence-based plan of care is only going to occur in the acute hospital. And so regardless of what electronic record system I'm using, or the patient leaves the acute care hospital, and even if they were using Epic on the acute inpatient setting and now they move to a skilled nursing facility that's using Epic, there is no Zincs Health skilled nursing facility plan of care for that diagnosis. So to the point Stacey was making is first, and Stacey was remaking the point that I made initially, that first, let's ensure that there is a Zincs Health evidence-based plan of care for that skilled nursing facility setting, whether they're using Epic or point-click care or something else. Then the next thing, and this is what the industry in general really wants, I believe, and that is that the plan of care that is initiated in the acute setting, that's individualized for that patient, and we document the interventions that have been performed and the patient's status and progress towards goals, that individualized plan of care now follows that patient and is further refined at the next site of care, whatever it may be. Again, the point I'm trying to make is that thanks to meaningful use, most hospitals and health systems have some type of evidence-based plan of care in the acute care hospital, but there's not much, if any, in the other sites of care. So that's our first opportunity, I believe. But the question then is, will people actually pay for that? So a lot of what we've seen in the past, people were willing to pay for this because there were meaningful use dollars attached to it. You had to check that box. But that's not true for the other sites of care. So the value prop that will get folks to pay for it, we hypothesize, is something beyond merely getting evidence-based content into those other platforms supporting those other sites of care. That notwithstanding, that still is the first step.
Well, it seems like ultimately the value proposition is going to be better outcomes. This is a way of getting better outcomes because the evidence, the same outstanding evidence that's been used in hospitals for 20 years is now being carried forward into all these other settings, and it's going to be setting appropriate. It's going to be patient appropriate. Does that make sense?
Yeah, that does. And it's also like it's not meaningful use anymore. Now it's accountable care because now the hospitals are responsible now, or hospitals, I use it with air quotes here, but now they're responsible for not only what happens in the four walls, but outside of the four walls to prevent them from coming back. So, I mean, that's our opportunity. And again, like I feel like we have, there's a part of me that says, let's just go out there and advertise. We have home health care, we have ambulatory care, we have SNF care, and make Nan do it all. Just kidding, Nan. But, see what that market is, because those ACOs now are responsible for those patients once they leave, where meaningful use may just have been a check the box.
Exactly. And they will, excellent point, because they will be facing penalties if they have hospital readmissions, avoidable use of ER, so the emergency rooms. So that combined with the value-based care models have become big drivers of caring about post-acute continuum of care. Yeah.
But to Jeff's point, will they pay? I mean, that's the question. And I'm not a marketing person. I'm a nurse, but we have people asking us for it. Stanford's asking us for ambulatory care. Ohio's asking us for home health. Partners ask us for home health. We have people asking for it. So, I don't know what the steps are to make it marketable, but I feel like we can at least start there.
Well, and especially if you basically already have the content, it's just the content resides at the acute care hospital, and the point where the treatment's going to happen is going to be outside of that setting. If you can push that into all these different settings, again, especially as value-based care becomes more and more the way things are, then they all have a stake in it, I guess is what I'm trying to say. There's a reason for them to need to do it. They have to feel the pain, I suppose, but if they are understanding that this is something they need to do, then I would think that then they'd look for a way to solve it.
Right.
If there are people questioning or asking for it, it seems like then there is a need, as opposed to, nothing more or nothing worse than the dreaded solution in search of a problem.
Right.
Right, and that's where, honestly, I probably should say this internally and not with Amendola on the line, but I feel like we're missing the boat. Like, I feel like if people are asking for it, why aren't we doing it? Sorry, I'll take earmuffs for those last 5 seconds.
Yeah, we're under NDA, so don't worry.
Yeah, that's fine. But Stacy, so let's just take a moment. Nan is developing content and delivering content for those other sites of care. So we're not totally ignoring it. I think it's just a question of have we proven a proof of concept that it's what they need, and then becomes something that's reproducible and scalable. Nan, am I saying that okay? Does that sound all right?
Yeah, that sounds right. Most of the content for home health and the skilled nursing have already been developed. But, yeah, I don't know. Sometimes I wonder why nobody is trying to sell to those facilities or home health agencies.
Well, I would question, Jeff. You said it's been developed. Where is it being utilized? I guess I don't have insight into that maybe, but that's where I feel like we're missing.
Yeah, probably this is an internal discussion, I think.
Yeah.
Well, I guess, the other thing, when you think about it, because post-acute care was left behind on the whole meaningful use thing, there are still a lot of those facilities that either don't have an EHR or don't have much of one. So if they had the content, if they had the plans of care and all of that, where would they put them? How would they get that into the hands of the clinicians?
Well, originally our Zinc Care plan of care is actually printed out on paper, and then and when the EHR is implemented, they started to put it in EHR. So even
right, that's a good point.
Paper printout is okay.
Yeah, in fact, sometimes it's even better in some regards.
But I guess my question is, are they thinking that way? Obviously, you can print them out, but would there be a hesitation because, well, we don't have an EHR, or is this something that they're going to look at and say, yeah, that's exactly what we need?
This is my own opinion. I don't think it would be a hesitation just because, like Nan said, we have a bridge strategy for clients to do it on paper in the interim and a downtime strategy. So in my humble opinion, I don't think that would be a deterrent. I just don't know that we've reached out to that market.
I'll pose an idea that's a little bit outside of this discussion, but related. We've already had a call with the Fire API work stream, and so my first thought is that's your interoperability technology. So why not build an app that allows them to have access to these plans of care and work seamlessly with what you currently have available for acute. And I realize that's on different platforms, but the Fire technology, that's a whole goal of it, is to provide that interoperability. And you can always go with paper, but of course it's stepping back a little bit instead of stepping forward into the digital future of healthcare.
Yeah. So, Kate, your observation is accurate. We're sort of dealing, the thing that we need to remember is Fire API is not widely adopted across all of the platforms in the industry. So I think as a future state, that's very appropriate. And that kind of lends itself to my question or statement earlier. I guess it's a question that this work stream is going to grapple with is, are we developing plans of care that will carry from one setting to the next based on interoperability standards between those platforms, or is there an opportunity for Zinc to become the transaction hub that is that interoperability? But the point that we need to remember is Cerner and Epic are barely into Fire, and they're ahead of most of the rest of the industry. So it's not a short-term solution, is what I guess I'm trying to say. I think you're astute in calling it out, but in order to address what happens today, that's where we need to come up with something that's not relying on Fire API. And I think we're circling it. It's to a certain extent dependent on what our clients want and need. Our clients are asked for a home health plan of care. They're not necessarily telling Zinc yet, and maybe it's because we haven't asked, that we're responsible to help that plan of care that was initiated in the acute setting carry to the home health setting. Those are the kinds of things that we need to explore and conclude.
Is this something that could be offered to those other settings as software as a service or something along those lines?
Yes, I think so. The question will be whether or not they're willing to pay for that. Part of the reason why the EMRs are not strongly adopted in the post-acute settings is just cost. They run on such thin margins, and there's no government funding that pays them for it like there was for the acute care settings. But I think there's a possibility. That's one of the other things that we need to test.
Yeah. I guess, just as you were talking, I was thinking that, perhaps the difference, one way to approach it is that this gives them something that they haven't had before, whereas they have a record-keeping system. It might be on paper, but they have a way of tracking this information. They don't really have that connection to the longitudinal plan of care or the disease plan of care or whatever that might give them better results.
Yeah, I think there's a real possibility there. If we can help those post-acute sites of care actually produce better results, therefore increase their tie to the network, to that hospital network, they may be willing to pay for that. But they're going to be pretty skeptical that we actually can produce those results, that improved outcomes will be as a result of adopting the Zinc Health Solution X.
We're getting more into the business model side of things, but if you are pursuing that and you want to have a pilot, if you could capture, their baseline, what they've seen in terms of outcomes and track those outcomes via metrics and reporting for 3 months, 6 months, then you have your perfect case study of results and a referenceable client as you move forward with this business model.
Yeah, that's right, Kate. Well, we have been having conversations around longitudinal care for years, and yet to date we've not really done any work that I'm aware of to establish what are the requirements, what are the industry requirements for a longitudinal care plan that Zinc could actually test and produce and then test. That's why, for this group, we're starting with definitions, and then the next are requirements, and then the requirements yield a minimally viable product, if we get that far. Jesse assures me we'll get that far. So Kate and Ken, we're putting a lot of faith in you guys to take all of this mud and find some clarity there that will help us to identify who we are and what we're doing.
Actually, what you all have stated, we do have a pretty good idea, speaking on behalf of both of us, but I know I was just jotting down some notes of what the value prop would be, and then Jeff, what you added with the plan of care being individualized for patients within acute care, and all of the interventions documented, and that this follows patients throughout the continuum of care. That, I think, weaves into the fact, I haven't put this together yet, but essentially that you bring evidence-based content and practices to clinicians throughout the continuum, resulting in standardized best practice care, better patient outcomes, all at a lower cost. So without wordsmithing that, it feels like that's at least a starting point.
Okay.
Did that sound right, or was I far off?
I think
that sounds right.
Yeah. No.
All right. So we have about 3 minutes left. Anything else you think we should keep in mind? As Ken appropriately put it, I think this was more of an organic messaging process in this call. With that said, is there anything else you think we should keep in mind in terms of vision, differentiators we should emphasize? Any other tangential information you think might be helpful?
No, you may find something as we complete the questionnaires that helps cement the light. And next steps, Kate, will you just walk this team through how you think our next steps will likely go?
Absolutely. So in parallel, thank you for that. In parallel to these in-depth phone calls, which we're doing with each work stream, we've done 1, 2, 3. This is our third so far. We have 2 more to go. There is the electronic questionnaire, which I believe each work stream is filling out, and it may be extended a bit beyond the work stream. Jeff, I've pointed the few project leads who've posed that question back to you if they are questioning who else that should go to. And once we receive the questionnaires, which gives us the detailed information from a broader group, and then we can compare that to the deeper dive in each phone call, then we will begin crafting the first draft of a value proposition, elevator pitch, and talking points. That's then delivered back to each work stream, and each of you all will be able to review, provide feedback, edit, and Jeff, my understanding is you may share that also beyond each work stream group for edits and feedback, which are then funneled back to us for the next round of revs.
Yeah, I don't know that we'll get the iterations beyond the work stream. Anyways, that's somewhat immaterial. Kate, can I just kind of tag an extra deliverable to this work stream, and that is any elements. So going back to Paul's question about a focus group of hymns, we're going to pursue that. Any guidance, suggestions, questions, things to test, etc., that you can provide to us will help us with that.
Great. So in other words, questions for the focus group is the additional deliverable or suggestions there.
Yeah. If I can ask you to provide additional deliverables free of charge, I'll take it.
Okay. Happy to help. Those will be fun. You're welcome. All right. Well, thank you, everyone. If anything else comes up, feel free to shoot me an email or send it to Jesse or Jeff. I'm sure both would be happy to send that on. Otherwise, have a great rest of your Tuesday.
Thank you, everyone.
Thank you.
Thanks, everybody.
Thanks. Bye.
Bye-bye.